everyone, and welcome. My name is Barbara Cochran. I am the director of the DeTourney Center for Healthy Aging here in the School of Nursing. And today, as most Tuesday afternoons, I'm representing the Northwest Geriatric Workforce Enhancement Center, which is sponsoring this geriatric healthcare lecture series. This is our Valentine's Day lecture, very appropriate. I do want to remind you, however, to also, if you haven't filled out a profile form, to check in with your site coordinator to do that. Also a reminder for those who cannot attend these lectures that they do get posted up on our nwgwec.org website, and that continuing education credit for these presentations live, or if you're sitting behind a monitor, but not if you're pulling off of the website, can be obtained. Your site coordinator has continuing education information that you can use to log on to the website at our uwcne.org website for getting continuing education credits for, I believe the amount is $45 for the entire series. Today I'm very happy to introduce Dr. Michael Chen. He is, his whole life is about hearts, but today is very appropriate for Valentine's Day, and Dr. Chen has special expertise in treating older adults with cardiovascular disease. He earned a bachelor's degree from Harborview College and then attended the University of Michigan in Ann Arbor, where he earned an MA and a PhD in psychology. His dissertation research focused on the influence of age and gender on patient-physician interactions. And then he entered medical school to obtain his MD. He came to the UW in 1999 for an internship in residency in internal medicine, and then also completed fellowships in gerontology and geriatric medicine and cardiology here. He's board certified in cardiovascular disease and has particular expertise to share with us on heart failure in older adults. And this time we'll also have a focus on multimorbidity. So welcome, Dr. Chen.
Thank you very much. I'm really pleased to be here, particularly on Valentine's Day. Although we'll be talking about heart failure, hopefully you'll leave more hopeful about keeping your patients' hearts healthy. My prepared remarks will probably not take the entire time, as I've built in a lot of time to answer questions, and I'm happy to do so during the talk if there are burning questions that folks have, or afterwards. I have no financial disclosures. I have three main goals, which are that by the conclusion of the talk, you'll understand that heart failure is a clinical diagnosis, not something that we can diagnose just based on a single test, even a sophisticated test like an echocardiogram. The second is to be able to distinguish at least some of the differences, whether it be etiology, pathophysiology, or treatment, between heart failure with a reduced ejection fraction and heart failure with a preserved ejection fraction, and we'll define these during the course of the talk. And then the third is to appreciate the impact of multimorbidity and geriatric syndromes on both the diagnosis and management of heart failure in older adults. So in the US, there are over 5.5 million people with the diagnosis of heart failure and about 550,000 newly diagnosed folks each year. And this is expected to double by the year 2030. It's a lot of people with heart failure. It's the #1 admission diagnosis in patients over 65 years of age and is diagnosed in 20% of all hospitalizations. It accounts for about 6.5 million hospital days per year and has a very high readmission rate over the next 6 months following an index hospitalization for heart failure, which has led to Medicare's focus on reducing readmissions by incentivizing or de-incentivizing folks whose patients are readmitted. Some series have shown a less than 50% 5-year survival following the diagnosis of heart failure. Because of all these things, heart failure is of course very costly. The prevalence of heart failure is influenced dramatically by age. You can see here in data that's relatively old but still relevant, that as you go from the 20s to mid-30s, you have a very, very low percent of the population with heart failure, and as you get to the over 75 age group, you're at about 10% for both men and women. And the median age of heart failure patients in the US is 75. And it's a highly morbid condition, as we've said. 85% of heart failure deaths occur in those who are over 65 years of age. So, as you know, the US and the world's population is aging. In fact, there's on the left, you see a street sign in Britain warning folks that there may be elderly people to watch out for as you're driving. This is a couple signs in Boston where there may be elderly people crossing, but you're not supposed to stop, apparently. This graphic just shows the dramatic increase in age that has already occurred and that projected in older folks, particularly in those over 85. That's a very rapidly increasing group of folks. So let's talk a little bit about heart failure and what it is. I mentioned before that heart failure is a clinical diagnosis, which means that we don't diagnose it based on a single test, whether that's an EKG or an X-ray or an echocardiogram or a cardiac MRI. It's a clinical diagnosis made with the support of tests, but is based primarily on history and physical exam. So a strict definition would be that heart failure is a clinical syndrome that can result from any structural or functional cardiac disorder that impairs the ability of the ventricle or ventricles to fill with or eject blood. That means it could be from a cardiomyopathy, something wrong with the heart muscle, whether it doesn't squeeze well or relax well, whether the clinical syndrome comes from a valve problem, so mitral regurgitation, for example, or aortic regurgitation, or aortic stenosis, or mitral stenosis. Any of these can cause heart failure symptoms and the syndrome of heart failure. The graphic here on the bottom panel is meant to distinguish what we call systolic heart failure, or heart failure with a reduced ejection fraction, versus heart failure with a preserved ejection fraction, so-called diastolic heart failure, where the squeezing function of the heart is normal, but it doesn't relax or fill well. And that's as distinct from heart failure with a reduced ejection fraction, where the squeezing, the heart muscle is weak and the pump does not work to eject blood. There are a lot of different etiologies for heart failure, as is probably obvious by now. The number one etiology would be ischemic heart disease or coronary artery disease. Hypertension is also important. Valvular heart disease is what VHD stands for. Alcohol is toxic to the heart, particularly in large, frequent amounts. Diabetes, other systemic diseases, idiopathic dilated cardiomyopathy, hypertrophic cardiomyopathy, all of these are potential causes of the syndrome. So I've mentioned these two categories of heart failure, the main distinction, heart failure with a reduced ejection fraction and heart failure with a preserved ejection fraction. Some of you are probably familiar with the term ejection fraction, and it refers to the amount of blood that's ejected, typically from the left ventricle, with each heartbeat. So the ejection fraction refers to how much of that blood is ejected. A normal amount would be over about 55%. So with each beat, over 55% of the blood that was there at the end of diastole, at the end of the filling period, would be there at the end of systole. So it's not that the heart ejects all of the blood with each heartbeat, but at least over about 50% of the volume that's there at end diastole. So heart failure with a reduced ejection fraction, or so-called systolic heart failure, is the most common type of heart failure in those who are younger, so less than 65 years of age. About 90% of those folks will have a low ejection fraction or poor pump function. The prototypical patient with heart failure with a reduced ejection fraction is a middle-aged man with a history of coronary artery disease and myocardial infarctions. This is a well-studied phenomenon or well-studied condition with many therapies which have been shown in large clinical trials to prolong life and reduce the burdens of heart failure. These are just two still frames from echoes showing both a normal-sized left ventricle, which pumps normally, and then this, if it was moving, would show a very poorly functioning left ventricle with not very much squeezing. So to understand why heart failure is a progressive condition, we have to think about what the body's compensatory mechanisms are to low cardiac output. So the mechanisms that the body has to deal with low cardiac output developed in what you might call prehistoric times, as our bodies were slowly evolving to how they are today. There was no coronary artery disease, there was no hypertension, and bleeding from trauma was the main threat to a long life. The compensatory mechanisms that we have to deal with low cardiac output from low blood volume are beneficial acutely, but ultimately they become deleterious, and these are mediated by neurohormonal changes in the body. So this just represents the threats to life in prehistoric times on the left versus big threats to a long life currently. So talking about these neurohormonal changes, when there's low cardiac output, the sympathetic nervous system is upregulated dramatically. You can measure high levels of norepinephrine in the blood. These have the function of increasing both the squeezing function, the inotropic function of the heart, as well as the chronotropic function, so it increases heart rate. And there's vasoconstriction, so the arteries constrict in order to maintain blood pressure. The other main system that's upregulated when there's low cardiac output is the renin-angiotensin-aldosterone system, principally upregulation of angiotensin II and aldosterone. Angiotensin II is a potent vasoconstrictor. It's also an adverse growth promoter, though. And aldosterone promotes salt and water retention, trying to increase blood volume, but as a deleterious effect, causes myocardial fibrosis. At the same time these systems are upregulated, there is some activation of so-called counter-regulatory hormones, including endothelin, nitric oxide, and prostaglandins. And the natriuretic peptides, atrial natriuretic peptide and brain or B-type natriuretic peptide. Unfortunately, these counter-regulatory hormones are not produced in amounts that are sufficient to counteract the negative effects of the sympathetic and renin-angiotensin-aldosterone systems. So while in the short term, if you have trauma, you fall and break your leg and have a lot of bleeding, you can maintain your cardiac output, your systemic blood pressure via activation of the sympathetic nervous system and the renin-angiotensin-aldosterone system. If these systems are upregulated over a long period of time, there are adverse consequences principally to the heart. So when you have heart failure and low cardiac output for a prolonged period of time and these systems are upregulated, they can cause kind of a cascade or a spiraling of progressively worse myocardial function because of these adverse effects. So what about heart failure with a preserved ejection fraction, or so-called diastolic heart failure? Well, the demographics of this are different, as I've mentioned. It can account for about 50 to 70% of patients with heart failure, depending on the population studied and the various ejection fraction cutoffs used and so forth. The risk factors for the development of heart failure with a preserved ejection fraction, so-called HFpEF, are advancing age. So while less than 10% of patients with heart failure, less than 60 have a normal EF, it's the majority of patients who are in the older age group who have this type of heart failure. Gender has an influence as well. 67% of elderly women with heart failure had a normal EF versus 42% of men in one series. And lastly, hypertension is extremely important. Left ventricular hypertrophy, which can lead to diastolic dysfunction, so poor filling of the heart, is a consequence of prolonged, particularly untreated hypertension. And nearly 90% of patients with heart failure with a preserved ejection fraction have the diagnosis of hypertension. So the pathophysiology of HFpEF is that there's impaired diastolic filling, and this leads to the body trying to hold on to extra fluid in order to increase filling pressures, so to, in essence, passively drive filling from the left atrium into the left ventricle. This can lead to elevated pulmonary venous pressures, decreased lung compliance, and increased work of breathing, leading to the cardinal symptom of heart failure, which is breathlessness, particularly with exertion. There can be impaired cardiac output due to the low stroke volume. This can, of course, lead to fatigue and this neurohormonal activation that I mentioned with heart failure with a reduced ejection fraction. Some of the major effects of cardiovascular aging also work to synergistically potentiate these other adverse conditions leading to heart failure with a preserved ejection fraction. So, for example, there's increased systemic vascular impedance, so the arteries stiffen, especially the larger ones like the aorta. This can lead to left ventricular hypertrophy and impaired diastolic function of the left ventricle, so impaired relaxation. There's diminished responsiveness to beta-adrenergic stimulation, so it's harder, it takes more for older folks' heart rates to increase, and their ejection fractions don't increase as much with increases in activity, leading to a lessened ability to increase cardiac output with exercise, for example. There's impaired mitochondrial energy production in response to stress. There's a decline in sinus node function, which can lead to bradycardia and symptoms from that. And there's impaired endothelial function, especially endothelial-mediated vasodilatation. What this means is that, for example, a patient can have poor coronary artery blood flow, even in the absence of a fixed stenosis, leading to angina and subendocardial ischemia, even in the absence of significant stenoses. So let's take a few moments and talk about hypertension. Hypertension is critically important in the development of HFpEF. As I mentioned, nearly 90% of patients with HFpEF have hypertension. The treatment of hypertension decreases incident heart failure dramatically by anywhere from 22 to 68% in randomized trials of antihypertensive therapy. And it's also the case that exacerbations of heart failure with a preserved ejection fraction are associated with hypertension. So this graphic, this table rather, shows several older large clinical trials which enrolled large numbers of older patients, not the oldest old, but older patients, showing dramatic risk reductions in the development of heart failure with treatment of hypertension. Other factors that can aggravate heart failure include medications, so starting new medicines which may have side effects that can lead to water retention and heart failure, such as NSAIDs. Dietary indiscretion, so we always have folks that are admitted around Thanksgiving or the holidays after having a big salt load. New ischemia or infarction, arrhythmias, particularly tachyarrhythmias like atrial fibrillation, sleep apnea, new or worsened heart disease of another sort, such as valvular heart disease, renal dysfunction, anemia, other things that can increase the demand on the body, so hyperthyroidism, for example, or infections. These can all lead to exacerbations of heart failure or new heart failure in patients not having previously been diagnosed with heart failure. So let's talk a little bit about multimorbidity now. Multimorbidity is an important problem, as you folks know, in older patients, and multiple chronic conditions affect a large number of patients, particularly those with heart failure. So 90% of patients with heart failure have at least 2 other chronic conditions, and about 60% have at least 5 chronic conditions. Geriatric syndromes are also common, particularly in the HFpEF group of older patients. These can include functional mobility impairment, cognitive dysfunction, falls, etc. And both are related to adverse outcomes, particularly mortality. This is a little bit of a complicated graphic, which is meant to demonstrate how common comorbid conditions or multimorbidity is based on in patients with various conditions. So you can see there are various conditions listed on the left part of the slide. And if we just look at heart failure, you can see approximate percent of patients with various other conditions. So you can see that there's a very high percentage of patients with 5 or more other chronic conditions. There's a slightly smaller but still important group of patients with 3 to 4 comorbid conditions, and a fairly small percentage of patients with heart failure that just have only heart failure or heart failure and 1 or 2 other chronic conditions. So what are some common medical comorbidities and geriatric comorbid conditions in patients who have heart failure? Well, we've already talked about hypertension. Ischemic heart disease is very common. Atrial fibrillation the onset of new atrial fibrillation can often precipitate the first episode of heart failure. You lose the so-called atrial component of filling, or the atrial kick, and that together with tachycardia can lead to reduced cardiac output and symptoms of heart failure. Other comorbidities because of common risk factors include stroke, COPD, CKD, anemia, etc. Geriatric comorbid conditions include cognitive impairment, which is seen in over 25% of patients with heart failure, and problems with mobility, which can affect up to 40% in some series. There can be problems, of course, with ADLs and IADLs. Incontinence, frailty, weight loss, and visual impairment are also very common in this population. So what does this mean? This means that the older patient with heart failure is dealing with and fighting off a number of different threats to their independence and to their overall health. And that's depicted here on this sort of Venn diagram showing all of the various ways that an older person with heart failure can have challenges. Specifically, thinking about diagnosis in a patient with multiple chronic conditions, the cardinal symptom of heart failure is dyspnea and exercise intolerance, following with dyspnea, fatigue and weakness. Well, these are very common symptoms. They may result from other cardiovascular conditions such as coronary artery disease or atrial fibrillation or primary valve disease. Or they may be from other medical comorbidities such as COPD or pneumonia, obesity, anemia, infections, depression, and the geriatric syndrome of frailty. Because heart failure is a clinical diagnosis or a clinical syndrome, we have some other tools that can help us try to tease out whether a patient with these complaints has heart failure or not, but it can be relatively challenging, particularly if a patient has these other conditions. So we look at symptoms, physical exam, and the findings of other testing, principally echo, to try to help us. So what about the treatment of heart failure? Well, in a lot of cardiovascular trials, we try to improve patient survival or reduce mortality. And we also want to reduce the progression of heart failure, reduce symptoms, increase exercise capacity and quality of life. And the main way we've been able to accomplish these things is with neurohormonal blockade, or reducing the neurohormonal changes which can accompany heart failure. And we've had great success, principally in the treatment of heart failure with a reduced ejection fraction, where we have a very well-defined treatment strategy, data from very, very large, numerous clinical trials, which have shown substantial improvements in morbidity and mortality. Unfortunately, the age group that we're mostly talking about, the population of patients with heart failure with a preserved ejection fraction, there's limited data. There are theoretic benefits to multiple agents, although there have been no therapies shown to prolong life. There is some data for reduction in hospitalization and reduction in symptoms, which are important endpoints, particularly in patients for whom their functional independence may be more important to them than their longevity. So this is a slide that I'm not expecting you guys to memorize by any means, but goes through the ACC/AHA, American College of Cardiology, stages of heart failure, going from stage A, patients who are at high risk for heart failure but no structural heart disease or symptoms of heart failure, to then stage B, where there's structural heart disease, for example, left ventricular hypertrophy, but no symptoms of heart failure, to stage C, where you have both structural heart disease and either prior or current symptoms of heart failure, to stage D, where there's refractory heart failure, and you may be considering advanced interventions such as mechanical support or transplant, or on the flip side of that, palliative care measures. This is distinct from the New York Heart Association class system of heart failure, which is what patients are functionally able to do at any one point in time. Patients may move in the New York Heart Association class system between classes and go from a worse class to a better class, whereas in this staging system, once you have symptoms or once you reach a stage such as stage B or stage C, you don't go back to a prior stage. For those who are interested, you'll note that there is a relatively well-defined and ordered treatment schema for patients with heart failure, principally heart failure with a reduced ejection fraction, where specific medications and lifestyle modifications are recommended at the various stages. In particular, in patients with structural heart disease and prior or current symptoms of heart failure, there are a number of medications which are important and recommended, including ACE inhibitors, beta blockers, diuretics when needed, aldosterone antagonists, angiotensin receptor blockers, digitalis, hydralazine nitrates, and then in some patients, biventricular pacing and defibrillators. These are the components of that well-defined treatment scheme that's recommended for patients with heart failure with a reduced ejection fraction, for which there's such strong data for improving outcomes. And again, this just lists those agents that I mentioned, including some of the more novel agents, which are just being introduced and are gaining a bit of a foothold in the heart failure community. And you can see it's quite a long list, and can add to trouble for folks who are already on medications for their COPD or other comorbidities. So as I mentioned, this is in distinction to heart failure with a preserved ejection fraction, where there have been a number of randomized trials, mostly in the similar agents that have been shown to be of benefit in heart failure with a reduced ejection fraction. But unfortunately, none of these have shown a mortality benefit. Almost all of them have shown some reduction in hospitalizations and a reduction in symptoms, though. So the Heart Failure Society of America practice guidelines recommend several things in folks with heart failure with a preserved ejection fraction, including to look carefully at the etiology to make sure of your diagnosis, to evaluate for ischemic heart disease and in particular active ischemia, as ischemia can worsen diastolic function. To be relatively aggressive about blood pressure management, and we talked about how important blood pressure is in even preventing heart failure. It's also important in the management of heart failure. Counseling folks for a low salt diet, to administer diuretics for symptoms of volume overload, although you have to be careful because these folks can go from a little too much volume to too little volume pretty quickly. There's sort of a narrow therapeutic window there. Should consider ACEs or ARBs for folks with indications for these, including those with atherosclerotic disease, diabetes, or multiple risk factors, and ARBs for folks who are ACE intolerant. Beta blockers should be considered for patients with prior MI, hypertension, atrial fibrillation. Calcium channel blockers in those with atrial fibrillation, particularly when beta blockers are insufficient, or if they have angina despite treatment with beta blockers or refractory hypertension. As I noted earlier, atrial fibrillation and flutter can be problematic for older folks with even just mild diastolic dysfunction because they can precipitate heart failure. So these are patients for whom we might consider a so-called rhythm control strategy or more aggressive measures to keep folks in normal sinus rhythm. And then enrollment in disease management programs for patients with heart failure or those with who are at high risk for repeated hospitalizations. Exercise has been shown to improve diastolic function in older folks, and regular physical activity improves exercise performance and is actually recommended for all patients with heart failure. Supervised exercise has been associated with the greatest improvements. There was a very large trial called the Heart Failure Action Trial, reported several years ago now, where over 2,000 patients were randomized to supervised exercise versus usual care. These are patients with heart failure with a reduced ejection fraction. And after adjustment, there was an 11% reduction in the primary endpoint, which is all-cause hospitalization or mortality. Heart failure disease management programs are wonderful if they exist in your area of practice. They have various models, but most are multidisciplinary and include nurses, dietitians, social workers, pharmacists, may include home health providers, a medical director, which you will notice I have listed last because they're probably the least important in terms of taking care of these folks after their medical regimens are set in particular. The goal is to individualize care, improve self-management skills and compliance, optimize pharmacotherapy, provide close follow-up so we can head off hospitalizations before they're urgent, and counsel about exercise, diet, and other lifestyle modifications. There are a lot of different models, and many have shown to have benefit in reducing hospitalizations, improving quality of life, and reducing costs. So what are some management challenges in folks with heart failure and multiple chronic conditions? Well, one is that we don't have a lot of evidence to help guide us, even in these large trials. I'll demonstrate how the patients that we're typically going to run across aren't included in a lot of them. So as an example, in a 15-year analysis of studies from high-impact general medicine and subspecialty journals, over 90% of them use multiple chronic conditions to exclude patients from their clinical trial or their research study. And an analysis of phase 3 and 4 clinical trials from 5 high-impact journals showed that about half excluded patients with disabilities, functional limitations, decreased life expectancy, cognitive impairment, patients who were not living independently or who had serious illnesses. And 20% had maximum age cutoffs to get into the trial. What this means is that we're often operating in a data-free zone, and that's also true in cardiology, as I mentioned. So these are 3 large trials of heart failure with a preserved ejection fraction, which excluded, in the case of the so-called TopCat trial, which was a trial of spironolactone, it excluded patients with systolic blood pressure over 160, atrial fibrillation with a heart rate over 90, or a life expectancy less than 3 years. The CHARM Preserve trial, another large trial of HFpEF, excluded patients who had persistent hypertension despite treatment or a life expectancy less than 2 years. And the irbesartan trial called iPreserve excluded patients with blood pressure over 160 over 95, a hemoglobin less than 11, and a life expectancy less than 3 years. And it was the only one of these trials to have a median age that was over 70. It was 72. Management challenges are demonstrated by what happened after publication of the ROUSE trial. So the ROUSE trial was a trial looking at aldactone in patients with heart failure with a reduced ejection fraction. It was published in 1999 to a lot of fanfare. It reduced treatment, reduced all-cause mortality, heart failure hospitalization, and heart failure symptoms. The average age in the trial was 65. It got a lot of press, and it led to a lot of patients being prescribed spironolactone, which of course is a potassium-sparing diuretic. The rationale for its use was to enhance neurohormonal blockade in the renin-angiotensin-aldosterone system. And after it was published, this dramatic increase was noted, and a study in Ontario, Canada found a 5-fold increase in hospitalizations for hyperkalemia in older patients. These patients were prescribed spironolactone for their heart failure, and interestingly, they had sort of all the risks without any of the benefits, and had no reduction in their mortality, heart failure hospitalization, or heart failure symptoms. Instead, they were hospitalized for hyperkalemia. And in fact, if you other analyses have shown that in this population, a lot of patients with heart failure were prescribed spironolactone, but not prescribed beta blockers and ACE inhibitors, which were background therapy in the ROUSE trial. And this study in Ontario showed that the average age of patients treated in the real-world practice was 13 years higher than the population studied in the ROUSE trial. So extrapolation to our patients, even from well-done clinical trials, can be fraught with some potential adverse effects. So what kind of recommendations can we make for patients with multiple chronic conditions when we're trying to manage their heart failure? Well, this is a table from a very nice article in a recent Clinics in Geriatric Medicine, and I apologize for just going through it a little bit. So the first recommendation is to focus on so-called universal health outcomes. So try to improve the patient's overall health, not just their heart failure health. So try to reduce all-cause hospitalization rather than heart failure only hospitalization. Look at their health-related quality of life with a validated tool. Discuss their responses and their feelings about their goals with them. Identify symptoms so that they can express them when they have them. And do some advanced care planning. Formally assess cognitive function, and that's because cognitive dysfunction is so common in this age group, and you can use your sort of test of choice. Focus on non-pharmacologic treatments where possible, so exercise can be beneficial for patients' overall health as well as their cardiovascular health. And I'm going to skip number 4, enhance care coordination. So communicate with other clinicians involved in the patient's care. So we do a lot of this trying to, not only in our heart failure clinic, having them see nurses and pharmacists intermittently as well as their physicians, but also communicate with primary care providers so that we may see the patient 1 month and they might see them the next month, and they can know what our plan was, whether it was to escalate therapy, de-escalate therapy, just monitor the patient's weight and symptoms or whatnot. And then minimize treatment burden. And treatment burden is something that we should think about in all of our older patients, and I'm sure you folks are doing that as well. Talk to patients about what aspects of care are the most burdensome. Is it the frequent trips to the doctor, or is it the multiple medicines, or is it the monitoring of their weight and fluid intake? Try to discontinue unnecessary medicines and reduce unnecessary appointments. This slide notes that, as I mentioned, the typical burden of an older patient with heart failure is that they have a lot of other chronic conditions. They have to take a lot of medications. They spend about 2 hours a day on health-related activities related to medication management and other self-management. They attend more than 15 appointments with their physicians each year. They may need assistance with more than one activity of daily living, and they experience hospitalizations for their chronic conditions. And these are also all very costly and can increase psychosocial stress and strain. So just kind of to recap, some of my goals were to have the audience recognize that heart failure is a clinical diagnosis. It's not one that you can make based on a single test, but rather based on a history, physical exam, and testing. The second was to appreciate some differences between heart failure with a reduced ejection fraction and heart failure with a preserved ejection fraction. That relates to sort of the prototypical heart failure with reduced ejection fraction patient who's a middle-aged man with systolic heart failure and coronary artery disease, as opposed to the prototypical patient with heart failure with a preserved ejection fraction who's an older woman with a history of hypertension. We have a very well-developed, well-defined treatment regimen for folks with heart failure with a reduced ejection fraction that has the strength of multiple large-scale clinical trials showing mortality benefits. In contradistinction to that is the recommendations for treatment of patients with heart failure with a preserved ejection fractions, which includes principally treatment of hypertension when it exists, but also considering rhythm management in patients with rhythm disturbances and volume management. And then lastly, to appreciate that multimorbidity is important in patients with heart failure, older patients with heart failure, that pill burden is not insignificant, as well as needing multiple appointments and so forth, and that heart failure in older adults can be difficult to both diagnose and treat because of comorbid conditions that they have, which can cause a lot of overlap, particularly in symptomatology. So that's just a brief summary, and should stand you well with the little quiz that we made. And then, I'd like to open things up for questions. Okay.
So, and you might want to repeat this, Dr. Chen. What duration and/or intensity of exercise is recommended for elderly patients?
Great. So I had a question about what duration and intensity for exercise is appropriate for older patients. It's a wonderful question, and it's basically an individualized thing. I don't think I can give you a set rule, particularly in patients who may need assistive devices or who may have poor balance. You'd hate to have them go out and try to run a marathon or go out and jog. Walking at an easy pace where they can still maintain a conversation is a good rule of thumb that I try to use for patients who can walk. Folks who live in a setting where there are things like stationary bikes or the new step, those are also great ways to help keep folks moving. I do recommend a focus more on aerobic type exercise, so something like walking, not necessarily running or jogging, but walking, as opposed to a big focus on weight training, although maintaining muscle mass can be important in folks, in older folks, particularly frail older folks. And I think consulting with a physical therapist before embarking on any sort of weight training program is probably a good thing. And then I see that Anchorage is noting that Tai Chi and yoga can be helpful, and I think those are great as well. And there are programs at YMCA's, for example, with chair exercises, and Tai Chi has actually been studied and shown to improve blood pressure control, and so that can reduce pill burden as well. So those are good suggestions.
Anchorage is also wondering what throws off your balance after a heart attack.
Oh, great question. So why is it that some folks after a heart attack have trouble with their balance? Well, that too can be multifactorial. I think a lot of folks' first presentation of their cardiovascular disease or their coronary artery disease more specifically can be a heart attack. And so all of a sudden you have a patient who's had a heart attack, so they're taking several new medications, not just their antiplatelet medicines, so their aspirin and Plavix if they've gotten a stent in particular, but they're suddenly on a beta blocker and an ACE inhibitor, and they may be on an aldosterone blocker, and so their body may be adjusting to having a much more normal blood pressure when they were hypertensive before. That's one possible etiology. Another is if it was actually a pretty big myocardial infarction, a big heart attack, then maybe their ejection fraction is low and their balance is poor because their cardiac output is not meeting their demands. A third possibility is they may, stroke can complicate myocardial infarction, not super commonly, but occasionally, so that can be another reason for poor balance.
And then you talked about this a little bit, but blood pressure goals as the patients age, there's been data that suggests as they age, the blood pressure goals should allow for higher blood pressures due to fall risk.
Great. So a question about what kind of blood pressure goals should we have as patients age, because there's been a lot of interest in that area, a lot of press coverage, because a lot of our medical societies have competing is maybe not the right word, but conflicting rather, blood pressure goals based on age. I think what's clear is that we don't have a lot of data in the very old age group. There have been one or two trials which have included 80-plus-year-olds. I think most clinicians would agree that we should be a little bit looser as patients get older. At what age should that take place, I think is a little controversial. There's one group has recommended 150 as a systolic blood pressure threshold in patients who are over 60. I think that's a little bit liberal for me. I try to, I think as a baseline of 140, and then think about reasons why I might want to loosen beyond that. So patients who have orthostatic hypotension, who have achieved 140, for example, but are symptomatic, then those are patients who you might liberalize. Patients with frequent falls, again, particularly those who are orthostatic, you'd want to be cautious in that way. Also, if they have a very low diastolic blood pressure, so significantly under 60, for example, that can impair coronary perfusion if you push too hard with lowering blood pressure.
Missoula is wondering, are there studies underway with more realistic exclusion-inclusion criteria for people with heart failure and multiple chronic conditions?
So great question. Somebody's asking if there are studies underway or planned to evaluate folks with multiple chronic conditions and heart failure. There aren't any that I'm aware of. It's a really tough problem. The researchers, to be sympathetic, are trying to do their best to show a benefit, and what they're worried about is watering down potential benefits by having patients not do well for some other reason. And so they want as pure an evaluation as possible. I think what the best that we can, sometimes the best that we can hope for is sort of after those randomized trials come out, we can look at more observational studies, and the strength of evidence from those is going to be lower. But we can do propensity matching and try to evaluate the impact of the intervention. But to specifically answer the question, I don't know of any that are ongoing.
And an interesting question, what about spices such as turmeric to help with overall blood health?
So a question about spices like turmeric and heart health. I'm not familiar with any trials that have looked at those in particular. Some other supplements have been pretty well shown to not be a benefit, and that includes like vitamin E, but I'm afraid I don't have a good answer about turmeric.
Well, and then segueing in, another question is about other supplements, and they ask about omega-3s.
So a question about omega-3 fatty acids. I think there's fair data for omega-3 fatty acids, particularly in the diet. So having a diet that's rich in them, eating fish that's high in omega-3s is associated with better health. In terms of recommendations for supplements in particular, there aren't any strong recommendations for them. So I think they have potential for benefit and may be supplemental to standard therapies.
Okay, and then what about dental health and heart disease?
Oh, great. So a question about dental health and heart disease. There is a link in there between sort of poor dental health and cardiovascular disease, heart disease. The common link probably being chronic inflammation, and you may be familiar with testing high sensitivity CRP to evaluate for cardiovascular risk, and that's something that we occasionally do in patients who are at intermediate risk and are younger to try to put them into a potentially higher risk category and potentially treat them more aggressively for their lipids, for example. And so there was previously a lot more research interest looking at potential for infections related to poor dental health, and I think mostly it's probably the common pathway of inflammation that there's a relationship.
And back to supplements, CoQ10.
CoQ10 is sometimes used in patients with who have some intolerance to statin therapy, and it can improve their tolerability, and so it's effective in some patients for that.
And then someone asks about any data on caregiver stress and heart failure, and I'm not sure if this refers to the stress of caring for someone with heart failure or whether heart failure is an outcome of caregiver stress.
Caregiver stress and heart failure. So I guess I was thinking of it as sort of if you're the caregiver for a patient with heart failure, that can put a lot of stress because of because of how tough management can be, because the clinical course of heart failure is that patients will have intermittent exacerbations, and they'll often look like they're, for lack of a better term, on death's door, and then we'll bring them back and they'll be doing okay. And it can be unlike a lot of folks who die of their cancer, where it's sort of a progressive downward spiral. The patient with heart failure, I'm sort of drawing a picture, may have a general downward trend, but have lots of ups and downs. And that can be tough on caregivers who don't exactly know what to expect, because we don't know what to expect. We don't know when the next exacerbation might be the last, or they'll bounce back and do okay for a while. So it's an important thing to investigate. It's an important thing for us to ask about in patients who have caregivers, how they're doing.
Do you have any information on particular decision support tools for ICD placement?
So a question about decision support, or how to decide who to refer for an ICD. So unfortunately, right now, there's nothing more sophisticated other than if a patient is on as much of optimal medical therapy as they can be, and their ejection fraction is still less than 35%, and their life expectancy is greater than a year, then those are patients for whom the guidelines would say it would be appropriate to refer for an ICD. Obviously, there's a little bit of wiggle room in there. A patient who has, who doesn't want to consider having, the potential for inappropriate shocks, or doesn't want to have procedures or whatnot, may elect not to proceed with a referral. But those are sort of the bare bones recommendations.
And then Anchorage is asking if you've heard of healing touch or polarity balancing the meridians for calming the heart. Not sure what that is.
I have not heard of those things. They sound good though.
How about heart health and whether a person received breast milk or not?
Question about breastfeeding in childhood and subsequent heart health. I'm not familiar with those studies.
Any questions here in the room? No, that's great. Okay, then I think we're done. Thank you so much, Dr. Chen.
You're welcome.
I learn something every single time.